3, 2, 1. Caroline Baker, you are the Director of Dementia for Barchester Healthcare. Sue Goldsmith, you are one of our partners at SP&P and our Director of Care Quality Services. Welcome both to the Care Home Show.
Simon.
Thank you, Simon. It's a pleasure.
Very good to have you both on board today. So, you guys have worked together in the past. You're both leading authorities within the dementia care arena, if you like. So it's a real pleasure to have you on the show, and really looking forward to just unpacking some of the kind of ideas, experiences, and insights that you guys have had over the years. So, Caroline, let's start with you. So, where did your dementia care journey? Where did it all begin?
Crikey, it began when I was 21. And I was never going to be a nurse, believe it or not. I actually wanted to be a policewoman. But I started as a care assistant after doing various jobs that I got bored with. And I just loved it from day one and applied to do my nurse training and started to do that 6 months later. And qualified 3 years later as an RMN.
Got you. And that was the beginning of a lifelong journey for you.
It was. I've always wanted to specialise in dementia care, I think, because when I was a care assistant, that was the area that I worked in on the dementia care wards. And I knew at that time that some things weren't right, but I didn't know how to put them right. And felt that when I started my training, that would help me to try and process what needed to happen and start to make those changes. Got you.
And you've spent largely your professional career trying to right the wrongs that you experienced kind of way back when, and looking to try and have a positive impact.
And some of those wrongs were mine, because I didn't know any difference at that time. And it wasn't really until I went to Bradford and listened to Tom Kitwood about person-centred care that it really, for me, that's when it all started to make real sense about how we should be looking after people living with dementia.
Got you. Well, I'm hoping that we can talk through kind of some of those life experiences that you've had, and some of the positive improvements that you've seen in the world in your career as well. But why is what you do so important to you personally?
I think it is because of how I started my career, because some of the things that I witnessed were really not nice, and it was quite difficult to get anything done about that at the time.
Sure.
We hadn't got the safeguarding that we've got now. There should have been, and it was those real, tear-jerking moments that that you go home but you were ineffective as a care assistant, as I say, to do anything about it. But I couldn't put my finger on what was necessarily wrong at that time. And it just became a real passion that I knew people living with dementia shouldn't be treated like that. And I'm not saying everybody was, and I'm not saying all the staff were the same, but there was some that just drove me to make a difference and to make sure that I didn't witness that sort of care again.
Got you. Okay, thank you. And then Sue, how about you? Where did your journey in dementia care, where did it all begin for you?
I kind of stumbled into the care home industry when I was at boarding school, and as part of our curriculum we had to give something back to the community. So I opted to go into a care home and visit when I was 14, and that was really quite an eye-opener, and I think even back then, to me, it seemed that there must be more to life than just sitting there waiting to die. So in the 2 years that I visited the care home, I probably caused quite a lot of trouble.
It's not like
which is very unlike me, isn't it, Caroline? By questioning things, why things were like they were, and then there was never any real answers apart from this is the way that we always do things. And got myself attached to a little lady who I'll never ever forget, who wanted to do a little bit more than just sit in a chair all day. So we would do things like dusting and going out for walks in the garden. We wouldn't tell anyone we were going, so that's kind of where the trouble came in. I think I was probably banned for a couple of months, and then I kind of snuck back in. But like Caroline, I was never going to be a nurse. I think you kind of get to that age, don't you, where you're 17, 18 and you have not a clue what you want to do. But I knew that because I was such a nosy and bossy person, that I needed to do something with people. So it was either be a teacher, and I probably would have been the worst teacher in the world, or nursing. So I chose to go and do my mental health nursing as well, because that was the part of people that had always intrigued me, really.
It's interesting, isn't it? Because you're basically talking about giving somebody living with dementia kind of meaning and purpose in what they were doing, rather than, again, just kind of sitting around waiting to die, which is obviously that's the kind of the almost like the some of the public perception around kind of how care kind of is delivered. What was radical about what you were doing was you just allowing somebody to go about living their life in the best way that they could, even with kind of their kind of cognitive challenges and things like that. So it's interesting. I can imagine you being the young rebellious type, but just doing it for absolutely the right reasons as well.
Because I couldn't see the reasons why we couldn't do it. I think, and that's what's so nice about a lot of the people who we work with now and who I've met over the years, that they have this attitude of anything's possible, you know, and you know, to work with people like that just really helps to move care forward, really.
It's just changing attitudes and
completely.
mindsets, isn't it, really, and the culture of care.
Well, we're definitely going to spend a bit of time talking about that in a little while, because I think it's a really important subject that all of us are very, very passionate about. So we'll definitely go down that line of thinking later on. But so tell me about your the journey, if you like, because you're starting out from where you have been to where you are today. There's a lot of stuff. There must be some incredible career highlights and things like that. So tell me a little bit about what that journey looked like for you.
Okay. Unfortunately, it still continued to be a little bit frustrating after I'd qualified, because as a staff nurse you were still sort of in the middle, that you'd go with your ideas. So we went to training school, as it was then, not university, and you'd hear about all these fantastic things, and your mind would clock away thinking, oh, I could do this, I could do that, and quite often, as you said, well, it's always been done this way, or we haven't got the money, we haven't got the time, etc, etc. And I remember feeling like a tent peg just being hammered into the ground, because I'd sort of surfaced as this brand new staff nurse, one with these great ambitions to change the world, and I was just being hammered down. So I decided to leave the NHS after 4 years and went to work for a charitable trust, who were absolutely amazing. And they really just let you flourish and blossom. And you know, the MD was actually an architect by background.
Okay.
But he did consider risk. It was wrong to say that he didn't consider risk, but he wanted to, you know, let people with dementia do as much as they could, which was just fantastic to hear. And we managed the risk around it. But he would always say, well, go and try it. And come back to me and let me know. So we tried a sensory room, which cost £10,000 back in the day, which was probably 20 years ago. And then we ended up putting them all in all the dementia care homes in extra care, which was fantastic. And that was just the fuse that sort of made me think, yes, anything's possible now. Actually, all I've got to do is sort of keep at it, demonstrate why something's working, or you know, start to do the research around it, and just get somebody to listen. And when you can go back with the positive outcomes and stuff, because it was only a very small study, but we stopped using PRN antipsychotics because we take people into the sensory room, and it continued afterwards. When they came out, they were still relaxed, and I remember him coming into this sensory room, and he was quite an energetic guy, and he was on the edge of this chair saying, oh yeah, it looks okay, but I can't really see what all the fuss is about. And as we were chatting, he literally started going further and further back into this chair and ended up spilling his cup of tea. And he said, okay, you've sold it to me. And that's when he agreed to put it everywhere. So.
And do you think, because he was an architect, because he hadn't come from a healthcare background, do you think that maybe some of the negative reinforcements come from kind of having a healthcare perspective, do you think? Because there's an element of being risk averse, and he was putting himself in the resident's shoes and just thinking, well, if I was living with dementia, then I'd just want to have free reign of my choices, and I'd want to have kind of a meaningful existence and things. Do you think that was part of his open-mindedness?
Definitely. And it was sort of anything was on the table. So as a new manager, I remember him taking us to a fire station and saying, it was part of the managers' meeting, that we were presenting a cheque to the fire service because we'd raised some money for them. And then he asked us to look up at the fire tower, and there's a 89-year-old resident coming head first down the fire tower.
Wow.
Oh, wow.
And that was his introduction to us, that we were starting to go on these Calvert Trust holidays, where we were going zip wiring and canoeing and sailing, and it was the best experience for me starting off in extra care, because they really were so encouraging and open-minded, and because they were small community homes. I think coming from that institution for me, initially people were scared that when they closed the institutions that people wouldn't be as safe as they were, that they'd feel more anxious, that they wouldn't be able to do as much because they weren't in the confines of the hospital, but actually they ended up doing more because it was a home-like environment as opposed to long tiled corridors and very large wards, and it just made you see that anything was possible once we moved into the community.
It's interesting because that must have set you off on quite a positive trajectory, because you've been in that kind of open-minded context. So what was kind of the next stage of the journey? What happened after that?
Well, after 10 years of working in extra care, I decided that I'd go back into the NHS because I felt that I was in a position now that I could make a change. And I was a clinical nurse specialist in dementia care. And I also worked 2 days a week for the University of Bradford on a secondment as a DCM consultant trainer. And it was a nice blend actually, because you brought the knowledge from the university within the specialist job and obviously the clinical part of the practice into the academic side. But I just found it so frustrating, Simon, because all that bureaucracy was still there. Even though I was in quite a senior position, it was quite difficult to effect any changes because there were 7 million people to ask before you could get a bit of budget in.
Yep.
We did end up getting 11 projects off the ground by me literally pulling teeth and trying to raise this money. And they're all for people in the community living with dementia and their carers. And it was a great time in that respect, but then the funding was pulled. And it was just, well, we haven't got this money anymore, and we need to put more money into primary care, and dementia care was just
swept off the agenda.
Insignificant.
Wow.
And I remember him saying to me, a consultant, and I will never forget it until the day I die, it's nothing personal, Caroline, but dementia care is a peripheral luxury.
Wow.
And that was the day I put my notice in.
That must have hurt a lot, given the fact that it is your life's work, still is your life's work, but I mean, you contributed so much to wanting to make a positive difference. Yeah, I can imagine that was very frustrating.
And because of all those projects, I was made a finalist for the Rising Star Award. My line manager had nominated me. And you think all that kudos that it brought for that healthcare trust. And
just to be stripped away like that, just parked.
Yeah, and it felt worse because we'd given people with dementia something and the carers that we then had to take away. And it felt worse than them not having it in the first place. And it just all felt so wrong on so many levels that I went home and looked at the Nursing Times and saw a job in a corporate company, whereas I started as a care specialist initially, but there was quite a lot of homes and quite a lot of dementia care homes, and I recognised that sort of my speciality was dementia care, so I became Director of Dementia care for them. I worked for them for 10 years and ran a programme to improve dementia care, which was great. We got some fantastic results and worked with a good team of people. And then I moved to Barchester Healthcare 4.5 years ago now. And we've been running another programme to, again, help people to improve dementia care and get a good, consistent offer, really, across, so that everybody's working in the same way.
Because I know that you and me have been talking quite a lot recently about you've got quite a lot of exciting things going on at Barchester at the moment, projects that you're rolling out. Tell us a little bit about what you've been doing, but then also why that's so important both for the team and for the residents.
It's changed slightly over the last 4.5 years. We started off with one programme that we piloted across 12 homes, which had some incredible outcomes for people living with dementia, such as reducing falls, reducing antipsychotics, reducing depression scores and pain scores. So we decided to roll that out across the company, which we had to half of the homes currently were accredited with that programme, and like I say, we had some brilliant results. But we've still got another half to get through. And in a way, it feels a bit unethical that we're sort of giving half our homes this and not the other half. So we've looked at a different way of doing it. Because although we've got quite a large team in one respect, there's 8 of us. Obviously, there's over 200 homes to get across, which are all across the UK.
Of course, isn't it?
Yeah. So we've redesigned it and looked at what we've called a foundation programme, where people self-assess initially and start to implement some of the criteria of champions within their own homes. And then as specialists will go in for the second part, which we're considering the extra stretch to help them to achieve the 1066 part of the programme, looking at the more specialist aspects of dementia care. So what we want to say is everybody to be working in the same way. There's some great carers, and that was one thing that really hit me about Barchester when I moved across there, that people were already very, very person-centred. So that bit was easy.
It's that integration, isn't it? It's that integrating it into the people's everyday practice, and not having programmes as bolt-ons. And I think, you know, the way that you've described it, and certainly conversations you and I have had, it is very much about having it as that integral part of working.
Yeah. But for some people, when I think back when I started as a care assistant, I didn't know some of the stuff that I needed to do. And sometimes I worked in the wrong way, not in a nasty way. So, for example, I'd want to do things for people because the message was very clearly being given at that time that people with dementia, there was no hope, no future. They were very disabled, they were very confused, they weren't able to do things for themselves. And so it's sort of a Florence bit took over, where I felt that I've got to help to reduce their anxiety and confusion, so I will do things for them rather than them struggle. So it wasn't until later on that you actually learn that that's very disempowering, and you're taking people's independence away. And what comes through so strongly from all the people that are talking about their diagnosis now and their experience is they want to retain their independence for as long as possible. And I look back now and I think that was such a terrible thing to do, but I didn't know that it was a terrible thing to do. I thought that was a good thing to do.
Is that because that was grounded in a very positive intent and instinct almost, if you like, but then that almost, I guess it's almost like maybe like there could be drawn some comparison of like smothering like a young child, I guess, in the fact that they're taking their kind of autonomy and their choices away from the person, again with the best of intent, but the actual outcome for either for the child or the person living with dementia, that it ends up being a negative thing and taking away rather than being a positive thing and giving.
Right.
So.
At that time we were also told they are like children.
We were, and there was that culture that existed that was made very, very clear, wasn't it, that the nurse knew best, and you as the resident or the patient, you just did as you were told. Yeah, and you did, and people did conform. You know, when you look back and you think about how many depressed people there was, how that whole air of apathy in a care home environment, because what would have been the point in fighting back? And people just didn't. They didn't. We as the nurses knew best, and we did everything for you.
Right, got you.
Because we were kind and caring, and we were kind and caring. Like you say, you know, it was done with the right intention, but we just didn't know at that time what we didn't know.
No.
And therefore...
And it was all very institutionalised practice.
Absolutely.
Because we needed to make sure that everybody had had a drink, that
Yeah.
everybody had been to the toilet. So people were taken at given times of the day. I remember as a care assistant, I don't know whether your experiences was the same, Sue, but when we were on the ward, people were literally lined up in
the
Buxton
corridor,
chairs.
yeah.
And then the first person was hooked up under your arm between two people, while a third person took their pants down and washed their bottoms, and people were waiting behind for their turn. And Simon, you look horrified.
It
And
does, yeah.
trust me,
Yeah.
it was horrifying, wasn't it?
I mean, some of the things were just, everything was about task. Everything was about
yeah.
doing at the person. We even had, in one place I worked at, we even had enema rounds. We had
Yeah.
enema days. We won't go too much into that, but, everybody even had to go to the toilet and at the same time and have their bowels emptied at the same time, and we were going to help them by administering these enemas. I worked with a lady. I was quite a young nurse then, but I worked with an older nurse who always made sure that she was on shift on a Wednesday morning because she was the enema queen. And everybody had an enema, and she really enjoyed doing them, which is quite scary in itself. But, nothing was left to chance. Nothing was left to the person's choice.
No.
And, we worked in that. We worked in that old culture.
Excuse me.
As Caroline said before, it didn't feel right. You couldn't put your finger on what was not right, when we were so young and just starting out, but you knew.
So it sounds like you've got an awful lot to have learnt from and to reflect on, which is got you to the point within Barchester that you're able to roll out the 1066 programme. Why 1066? I don't think I've asked that question before.
A lot of people ask me this. It's nothing to do with the Battle of Hastings.
Nothing.
Is
Okay.
it anything to do with the codes on the doors in care homes?
No.
That's good.
Because a lot are, I agree.
Most are 1066.
Initially, it was literally because it fell with how the criteria sat. So there were 10 questions, or 10 criteria rather, that went across the care home regardless of whether you were providing general nursing care or dementia nursing care. So things like life story, person-centred approaches, etc. And then 60 were specialist elements, and they were broken down into 10 themes of 6. And then there were 6 additional criteria where people were implementing their own projects and things. So I just thought it was quite snappy. 1066, really.
Well, people certainly aren't going to forget 1066,
no.
are they? For the reasons of the Battle of Hastings, of course. So,
Yeah.
And what's the? You talked about some through some of the kind of the practicalities and the how the course has been kind of created and delivered and rolled out. But what's the vision, and what are you looking to achieve with the 1066 programme? I know you mentioned consistency, but paint a little bit of a wider picture around what you hope to, the impact that you hope to achieve with the programme.
I didn't mention that the programme also comes with a lot of training as well, so that we're helping people not only to look at what the criteria is, but actually what's the rationale behind that criteria. And trying to get people to think for themselves how they might improve within their own environment. So it's not about us just going in and saying, well, this would be fantastic and that would be marvellous, because we want the staff to come up with their own ideas, and we want to get them into a position where, they're like, when I was a care assistant, but they are being listened to, and we're going, oh, that's a fantastic idea, let's try it. So the programme came with an allocation of money to enable people to create their own projects. And some of the interventions that we used and some of the activities that were tried, we've continued with. Some of them we decided not to pursue, but those that worked well, the team actually wrote a book last year.
I was just about to mention the book.
Yeah.
You and the team wrote, didn't you, about activities?
Well, to be fair, I only edited this one with Jason. Well, I've got one chapter in it, I think, but they each wrote a chapter which was just brilliant about whatever intervention it was that really floated their boat, if you like, with a case study attached to it to show how it worked well.
Mm-hmm.
And some of the things that we've seen and some of the things that we've heard have just been fantastic. And for me, that's, you know, we have awards every year, 1066 awards, where the specialists will present each of their homes that have gone through and pick out 2 or 3 things where it's made a real difference for an individual resident within that home. And some of the stories you hear, they're just absolutely incredible, where, you know, people's lives have just changed. And there's so much negative media about care homes, which is so sad, but we don't get to hear those joyous moments, and they are joyous moments. My own nan, she didn't have dementia, but she lived on her own, and after she'd gone into a care home, she was a different person. 3 months down the line, because she was being looked after properly, because she perhaps wasn't cooking very well for herself, as we knew when we went in and got the mouldy cheese out of the fridge, etc.
Oh, bless her.
But because she was socialising and because she was with other people.
It's a completely different level of stimulus, isn't it?
Yeah,
It's, again, social interaction, better quality of food,
That's right.
relationships, whether that be residents within the home themselves or whether that be by being the beneficiary of good quality care and things like that. It can make an incredible, immense impact on somebody's life and their well-being.
But sometimes just finding that key to unlocking whatever it is for that person, it's a hard job sometimes. It really is a hard job, in as much as you're trying to sometimes get to the bottom of why somebody's distressed, because they're not always able to tell you. So if you can actually find that key to try and turn it around, you know, and sometimes it's something as simple as headphones with a playlist of their favourite music. We've been using pillows with speakers in as well for people that have been nursed in bed. And sometimes it's just really small interventions that can make such a significant impact for people.
There's a few videos on YouTube, isn't there, of people who literally come alive. You can literally see their whole physiology change. They're non-verbal, they're completely disengaged. You play their favourite track from their childhood and they're beaming and they're singing and they're enjoying it. And it's like, it's really impactful just watching that. Like I remember the first time I watched it, I was a bit like, bloody hell, that's it's really impactful, but it's wonderful to see, because you've taken somebody from being completely disengaged to being literally, to use your words, joyous, which is immense. It's big. Excuse me. It makes a big difference in people's life ultimately at the end of the day, doesn't it? So.
We've just introduced some magic tables. They're
fantastic, aren't they?
Oh God, they really
good.
are. And I think not just for the residents. Obviously, our primary aim is for the residents. But I think sometimes when the relatives visit, and if people are in the more advanced stage of dementia perhaps aren't able to communicate as well, it's something they can do with the person without actually having to, you know, ask what they'd have for breakfast and things like that. But the staff as well, because I'm hopeless. If you put me in a room with 12 people and said, right, Caroline, I want you to do some marvellous activity, I would be really stuck apart from doing a sing-along or whatever. Excuse me. And that is something that I can actually really do with the residents on an activity level, because it's just so easy to do.
I think it's a real icebreaker, isn't it? It's, you know, I think a lot of people do struggle with communicating and thinking, you know, how it's difficult, isn't it, sometimes to talk to somebody if you feel you're getting nothing back. But I think it's going back to never assuming that the person isn't understanding what you're saying. But I think the magic tables and some of the tech that's out there at the moment is really, really helps with, you know, just bridging that gap for conversations to start happening.
Do you know, the thing we've had the most success with, aside from the magic tables, is the robotic cats.
Really? Yeah.
Well, that was part of the project when we were trialling it in the initial phase, and I sourced them from America. And they're about £120, I think they are. So we had a cat and a puppy. The puppy isn't all that, to be honest. It's it just yaps and turns its head around. But the cat is fantastic because it purrs and it rolls on its back and you can use the brush to brush it. And so many of the residents really, really relate to it and start to call it their own cat's name and ask you to make sure it's in the basket, but you can have all these conversations. It kicks off a real reminiscence session because you're talking about how they care for their cat at home and how many cats they've had, and they do get a little bit messy sometimes because they do try to give them some food and things, but you can sponge them all down. But they've been a real hit. I love the idea of some of the robotic stuff, although not robots in care.
Have a little chat about robots in care later, definitely. That's an interesting subject. I think I might have mentioned, but so there's a gentleman by the name of Chris Papadopoulos, who's a professor at Buckinghamshire University. He spearheaded the project with Pepper. So he worked with the guys at Advinia to effectively to kind of almost like prototype or trial the robots in care project, and he's bringing Dr. Sanjeev Kanoria, who's the chairman of Advinia, for an episode in the future. So that'll be an extremely interesting episode. Obviously, robots in care at that level, it's quite contentious. I'd say it's quite emotive and things as well. I guess I'm still kind of forming my own opinions around how I feel about it, but it'll be really interesting to sit down with those guys to talk on that subject. But more on tech later. Thank you for sharing the journey as well. It's really interesting to kind of hear kind of where you started out and kind of where you are today, and kind of a little bit around what the future might look like as well. So it's a really interesting story. Thank you.
Thank you.
How about you then, Sue? Tell us about what was your journey like?
So a little bit like Caroline, I was going to change the world. I was going to be this one woman wrecking crew that was going to change everything for the better.
See, this is why you're really good friends, isn't
Yeah.
it? It all makes so much sense
we
now.
pretend that we have changed the world at times, don't we? So yeah, I did my training up in the northeast, and wasn't particularly enamoured with elderly care. It seemed to be very much task-orientated conveyor belt care, and that seemed even a little bit too much for me to be able to change at that point. But then I was really lucky, and I got this community placement. It was a day centre placement, and it was the early 90s, so it was just at the time where we were shifting back into the community and the institutions were closing down, and it was absolutely phenomenal, the support that nurses and social workers and occupational therapists who were based at this day centre were making to support people to remain in their own homes. So we would go out and do assessments and see what people were struggling with, and then invite them to the care centre, to the day centre, really to practice, so that they could maintain their skills. And that kind of reinvigorated my passion really for elderly care. So that was quite early on in my nurse training, and by the time I'd finished all of my placements and my training, I'd caught the acute admissions bug, and I was going to be super nurse in working with people who were just adults between the ages of 18 and 64. But somehow my timing was a little bit off, and one day I found that I kind of come home pregnant. So didn't fit with acute admissions very well. So I figured I'd go and have a far more relaxing kind of role. And that's when I took a night nurse's position in a care home. And how wrong was I when I thought that was going to be relaxing, because we were just so busy. And it really opened my eyes to how care really shouldn't be delivered. And I think that was at the point where I felt like I needed to start being a little bit nosy and a little bit more bossy and changing things. So then I next moved on to work in a very small 13-bedded dementia care home. That was really a trial for that community. They didn't have anything like that, and it was quite a small village mentality. So working there was with very like-minded people was fantastic, because we kind of made the rules up as we went along. We made the rules up according to what the residents, people who were living there, wanted to do. And without knowing it at the time, I think that was my first real taste of person-centred care. Because we were there for the residents, they weren't there for us, and you know, it was just a fantastic place to be. After a few more years, kind of, I wouldn't say home hopping, but always looking for something different, always looking for homes that were doing something different or trying to make those improvements. A little bit like our own Martin Murphy, I thought, how can this be so difficult? Why do people just manage these homes so badly? It cannot be that hard. So I thought, I'll go and do this myself. And I did. And after day one, I thought, now I know why this is so hard. And I started with a corporate company, so I was one home out of hundreds, really. So not only did I have to learn the role of being a registered manager, but I had to learn the kind of corporate systems and standards and policies. And then, of course, I had to get to know all of my 79 residents and my what sometimes felt like 900 staff. But I stayed there for 2 years, and we had a good home. We built up a good reputation, and we actually delivered, I thought, good care. I think looking back, what I wasn't particularly good at was empowering my team. Because if I went away for a week, I'd come back to 10 weeks worth of work. And I think at the time I used to kind of like that, because that meant that, you know, that home needed me. It took a few more years for me to realise that actually what I should have been doing was empowering my staff, so that home didn't need me. So when I left there, I was lucky enough to work with Caroline, and we worked together in a central dementia team for many years, didn't we? Going around the country, living in hotels, still trying to put the world to rights, and thoroughly enjoyed it. Learnt so much from amazing people, Caroline and all of our colleagues, and you know, external people that we were lucky enough to meet and work with as well. So and then of course I came to you, Simon.
Did indeed.
I did, yes. And I'm sure you look like you've aged about 10 years since I came to you.
I don't know whether I'd necessarily attribute that to you personally, but yeah, all I can remember, I remember being with Rob, our colleague Rob, and us having a discussion around the case of what do we need to do next, how do we broaden our service offering, and he kind of said, well, we need to hire somebody with a clinical background, and preferably somebody with dementia. I know just the person. You need to hire Sue Goldsmith. Okay, fair enough. So it had a very similar process with Martin as well, in that I was basically told by my team exactly who I should hire, then went out to market to go and see what the market was basically saying relevant to potential candidates, and then realising, oh well, that's why I got told that this is the person that I should hire, and obviously delighted that I did, and yeah, we've been working together for, is it more than 2 years? It is more than 2 years, isn't it? 2
years in June it was, yeah.
2 years in June. So Sue, it's obviously been a pleasure working with you for the last almost coming up to 2.5 years. So for the audience, explain a little bit about the types of projects that you get involved in with SP&P.
So a big part of what we do is about helping our clients to develop high-performing teams, really. So I tend to do quite a lot of work around the culture of care homes and pointing them in the right direction, really, and guiding them and coaching them through developing their systems, their people systems, which obviously is their culture. That's really exciting, because I love to see people develop and try new things and really start to blossom and flourish. And I think it's like you said, Caroline, you know, some of the ideas that people come out with are just absolutely out of this world. And to see them bring those ideas to fruition for the good of the residents is great. So I do a lot with teams and culture. We help people as well to aspire to outstanding, and we're really lucky actually at SP&P because we have Pradeep Patel as our colleague, and he, prior to coming to us at the beginning of this year, he had his own portfolio of care homes, and a number of those were outstanding. So I'm able to pick his brains, which is great, and learn from his experience as well. So we are working at the moment at developing an outstanding toolkit, and that's really exciting. From a dementia viewpoint, I've been doing some work with a very special client, fantastic gent and leadership team, around their dementia strategy. So we are very early on in that journey, and we started that last week. But I'm looking forward to watching them grow as well, and watching the team take ownership really of the strategy. So yeah, lots of exciting things. Yeah, still doing my dementia care mapping. Was trained by a fantastic lady who's sitting not seconds away from me, and it still is one of my most favourite things in the world. I think again because I'm very, very nosy and I like to sit down for long periods. So,
but it's those, again, capturing those joyous moments, isn't it, through observation, where sometimes because you're busy you wouldn't necessarily see it because you're sort of walking past, but some of the conversations that people have that don't necessarily follow the same path, but they're sort of totally in sync, aren't they?
Completely. And seeing the relationships between people who live in the care home is just marvellous. And also to be able to make those recommendations that have such a direct effect on people's well-being is really, it's great.
What I really enjoy about the work that you do, Sue, is the fact that you have a really intrinsic understanding of people and culture, but then how to use that understanding of people and culture relevant to driving improvements in care, whether that be residential nursing or dementia care, because you understand those fields so deeply. So kind of the connection of those two worlds, and then how that then stacks up against our clients who are, whether they're in a position where they're looking to develop a dementia strategy, or whether they're aiming for outstanding or building their own benchmark of outstanding. It's building in their kind of foundations and things from a systems perspective, but then empowering the teams to then ultimately to go and deliver on the projects that they're looking to achieve is really, really impactful. So it's good stuff to watch.
It's excellent stuff to be involved with as well. Good.
Well, thank you guys. I'm going to change gear just a little bit, and I'm going to ask questions for kind of both of you, and either individually you can answer them or you can answer them together. But they're things that are kind of going on within the world of dementia that I really, really appreciate your perspective on. So I guess kind of question to both of you, kind of where was dementia care when you entered into your career? What did that look like typically?
Well, I think Noah was in charge, wasn't he? And it was just coming out of the ark, really. It was really...
It wasn't good, really, was it?
No. And I think we touched on it before, didn't we, when we said we knew something wasn't quite right, but we didn't know what we didn't know at that time. No. So people got sucked into, and you can see how that old culture became stronger and stronger, didn't it? Because new people coming in got sucked in, really.
It was all very much doom and gloom, wasn't it? There was no hope for the future for people living with dementia, really. It was just desperate. It was just all the Ds, wasn't it?
It
They've got
was.
dementia, it's desperate, they're going to die.
Yeah, and it was waiting to die.
Yeah.
It was keeping people shiny and clean
Yeah.
and well fed and watered
Yeah.
and safe. And that was as much, I think, 20, 30 years ago that people hoped for.
Yeah.
There's no meaningful life experience in any of that, is there?
No.
It's just the practicalities of existing rather than living.
Yeah.
And there was no meaningful purpose to a carer or a nurse's role in those days. You weren't allowed to
No,
think
you
for
definitely
yourself.
weren't seen as specialists. I don't know whether it was the same for you. I remember when I was interviewed for, when you'd qualified, you then had to be interviewed for wherever role you were going to go into the hospital. And they asked me if I'd got a preference as to where I'd want to work, which they do for everybody. And when I said dementia care, they sort of almost fell off their seats. And
What, like, why would you want to do that type thing? Or,
yeah,
really?
because
Wow.
when back in the day, people would move to dementia care if they hadn't been very good people.
Or if they'd be naughty.
Yeah.
So there was.
As part of almost a disciplinary measure.
Oh, okay. Wow. Okay.
Because it wasn't seen as sexy as acute psychiatry, and so if you wanted to work in dementia care or elderly care, as it was called then, it was, people thought you got no career prospects almost.
Wow.
It was bizarre. So thank goodness, that things have turned around and moved forward, and I mean, it's just, it's crazy to think about now, isn't it, really, when you look
It's
back?
really, and you look back, and I think the secret is not to allow those past experiences to drive you and to keep you moving in the right direction, but not to dwell on it to such a point where you beat yourself up for being a part of it.
Yeah.
Because everybody was a part of that.
Yeah.
And it took a long time to start moving things in a more positive direction. And there's still room for improvement, and there is still some homes that still need to move out of that old culture.
It's interesting, isn't it? Because you've seen the world come along such a long way from the perspective of dementia care. I'm sure there are still, as you say, there are still remnants of that around, but the world has moved on an awful lot since then. So, how do you feel that dementia care has changed fundamentally since you've been involved in dementia care?
For me, it is the absolutely embedding of person-centred approaches. So, you mentioned about when you took over as home manager. When I was a home manager, it was all about that, right, now I've got this licence to do things in a completely different way because I'm the manager of the home. And I can remember this guy walking up to me. I'd only been in the home a few days, and he hadn't had a shave. And they looked at me, the staff, they were absolutely terrified, and they said, "Caroline, we're really sorry. It was about 10:30, 11 o'clock. We haven't managed to shave him yet because it was really eaten out and blah, blah, blah." I was like, whoa, what's the issue here? Well, we haven't got him shaved. And I said, well, if he doesn't want to shave, he doesn't want to shave.
Yeah, let's not shave him if he's not up for it at the moment.
But they were so distrustful of me for the first probably 6 months because they thought something was coming around the corner. Whereas
Do you
I
think
was
that
saying,
they were trying to, did the team that you were working with, did they almost think that you were trying to trip them up somehow?
Yeah.
Wow, okay, that's
because
interesting.
they'd worked for a manager previously
More
that
of a kind
would
of
have said,
autocratic type of...
I want all the beds done by 9 o'clock.
Yeah.
I want everybody shaved by 9:30. So, and the fact that I worked on the floor with them as well.
Unheard of.
Yeah. In fact, even the inspectors, I had a warning off the inspectors because I was working on the floor, because they thought it was a way to save the charity money, that I was
really?
replacing an agency nurse. I actually had two warnings, can you believe that? Never been told off in my life. But yeah, me working alongside them on the floor enabled me, A, to get to know the residents really well and really quickly, get to know the staff really well. And we used DCM a lot at that time. to try and navigate our way through what needed to change, but getting the staff on board to do that with us. I've forgotten what your actual original question was, Simon. I'm really sorry.
So just to make sure that I've got it absolutely correct as well. So what's changed in dementia care since the beginning of your career? So
I think without that bureaucracy, it's so much easier, isn't it, to be able to deliver person-centred care. And actually, in fairness, when we first started nursing, probably the staff ratios weren't as high as they are now. So I was working on an admission assessment ward, so you were constantly having new people. So that was in itself could take up more time. And there was probably there was 4 staff to 32 on the ward, so that would be 1 to 8. Right. So in fairness, there probably wasn't as much opportunity, so it had to be a little bit more task-driven. So the staff ratios were a lot better that enable you to be more person-centred. But I think it's just so much easier to do it the way we do it now, because obviously it's right for the person, but if the person's receiving the right care, person-centred care, they don't become distressed. And that's where most people just spend most of their time is trying to resolve people's anxiety
because they're being pushed into some kind of cookie cutter type. This is when this happens. This is when this happens. And if you don't want to have a shave that particular morning for whatever reason, then being pinned down and being the recipient of somebody shaving you is going to be distressing, isn't it? Like if nobody would like that in any way, shape or form. So one thing that I wasn't necessarily planning on asking this today, but it's something that both of you are experts in. Tell me a little bit more about. You mentioned dementia care mapping. I think given both of your level of expertise, it'd be really interesting just to explain it. Tell us a little bit more about dementia care mapping and what does it mean as a tool? What's the benefit for the residents, and how does the process work, if you will?
Well, really, it's a way of trying to establish how the person with dementia is experiencing their care within a care home or similar environment. Because if they're not able to tell you, so it's difficult sometimes to carry out a survey of people living with dementia because they can't clearly say, my care is great, I'd give it an 8 out of 10. And it's a really good way, isn't it, of trying to assess how that person is experiencing the care, but what they're actually doing, how they're responding to what's actually happening. And it does look at staff interactions as well, be they positive or negative. But we were always trained that it's absolutely not to be used as a beating stick. It's all about us learning, and sometimes we do things because we don't know any differently. But if we could do them again, how might we do them differently? So my example of helping somebody button up their shirt or whatever because they were struggling, if I actually saw the impact of that through DCM, that perhaps that person would go into ill-being because they were starting to get frustrated because I'd overtaken them. And you could speak to that member of staff and say, okay, we know that you were trying to be really helpful. Well, you wouldn't actually speak directly to the member of staff, but you'd feedback to the whole group. But if we went back again and had that situation, knowing that this person was becoming a little bit stressed about the intervention, what might we do differently this time so that it was a proactive thing and a positive thing? But it's really good to help with care planning, isn't it? And
I think it's great. It's like you said, it gives the opportunity, and you have that luxury, because it is a luxury to be able to sit and do such an intense observation, where your care staff and your nursing team, they don't have that luxury. They're in the role, and therefore they may not always see the impact of the things that they do. And I remember mapping a good few years ago now, and a carer interacted just for a few moments with a lady, and had no response from her. So it was very short. So she left, but the whole look of relaxation and the smile on the lady's face after she'd gone, because of the direct engagement, was something that the carer couldn't possibly have seen. So it's fantastic to be able to feed back things like that, to encourage people to continue doing these things, because you might not see it, but you are having, a really positive impact.
I think that's one of the biggest things with DCM, that because in general nursing terms, in general care, where people haven't got any cognitive impairment, there's lots of reciprocity, isn't there? You get lots of that lovely fit. Oh, you're a fantastic nurse, you're a lovely nurse, thank you very much. You get a box of chocolates. And sometimes for our carers, they don't always see that they've had that impact or made a difference. And so however much we could say to people when they finished a shift, oh, thanks ever so much, you've all been fantastic, see you all tomorrow, to be able to use one of those examples and say, what you did with Mary today was fantastic. I know you only spent a couple of minutes and I saw you walk away. You looked a bit disappointed that nothing had happened. But let me tell you, Mary's face, just after you turned away, was beaming. What a fantastic thing to be able to feed back to the staff. And so it sort of replaces that bit of feedback that the person might have been able to give them had they been able to communicate themselves.
What I really like about it, because I've read a number of Sue's dementia care maps now, is the fact that it's done in the context of a third-party view. It's objective, so you've got your quantitative and qualitative kind of framework in which you kind of consume the information from the observation and things like that. And I know this is something you're massively passionate about, and I'm no doubt that you are as well, Caroline, from what you've just said there. But it's a case of, okay, so we've got all these learnings from this observation, so we've got that kind of baseline understanding of how dementia care provision is being delivered. How can we use that as the baseline, as the framework to say, right, okay, what can we do? What can we do better? And again, where Sue's work, I think, comes into its own is how constructive it is, and how it's sometimes you've got to deliver bad information. How many you've got to say, actually, you know what, that wasn't the best of interactions because of this reason, this reason, this reason. That led to the resident experiencing this and this. Obviously, that's not what we want. But we recognise that that's an issue. So, how, again, to your point, how can we do that? How can we do that better? And it has been the foundation of a lot of our projects, hasn't it? With new clients, where they're looking to get that baseline level of understanding. Because a lot of people, a lot of operators, they recognise that either some of them they recognise maybe they're not doing such a good job, but they've got the right positive intent. Some of our clients come to us and they invest in that service when they are smashing it, but they want to know what's that last 5-10% that we can do to really, really make sure that we're really refining everything. And it's so, because it is objective and because it's so comprehensive as well, it's a really fantastic tool.
And it is great to measure, as well.
Yeah, it is.
So when you go back and they can see that they've moved above their home average, or their interventions have made that difference to improve well-being.
And I think that's that can be the turning point for a lot of individual care and nursing staff when they see the impact of their changed practice, and it just makes them, I don't know, they want to take on the world, and they really want to roll with their idea. Completely, and that is so good to see.
It comes back to the culture thing again,
absolutely.
isn't it? It's about the people operating system. It's about how can you get people
But
leaning into what they do.
When I was managing this big care home, after I'd been to do DCM, I thought we were really person-centred. I've probably told you this story before. And I remember at the time Tom Kitwood giving us this equation that if you ended up with this equation, then you were in one of the top 10 care homes in the country. I thought, I'm going to go back to him and he's going to see that I'm in that top 10, because I thought I knew the staff really well, I thought I knew the residents really well, I thought I knew the relatives really well. And I sat and did this observation for 6 hours, and oh my goodness, I was absolutely... Well, I went home and cried. And I thought, what a terrible manager I am. But actually it was because I'd been working alongside them as well.
You were in it.
I was as busy as they were.
Yeah.
And so I didn't see half the things either. But we just sat down together, and that was us moving forward. But that first map, it was just like, oh, crikey. So it even as a manager, thinking it was really good, it really gave me some fantastic insights. I mean, it's quite a complex tool to learn, isn't it?
It is.
And there's 24 codes and lots of operational rules. And
Yeah.
but yeah, it's really good. We've developed a bit of a simpler version at Barchester now, because primarily because I want the care staff to be able to, and that's not being disparaging to care staff, but because it is quite complicated, isn't DCM? It's a 4-day course. And it's great for research, it's great for in practice as well. But I wanted more of our care staff to be able to sit and do what we do.
So it's making it more attainable for them.
Yeah,
that makes sense.
So we've got a very simplified version which couldn't be used for research, but it does help us in practice. So.
And I think that's it, isn't it? It's great to develop things, but I think, like your observation tool, it's very much keeping focused on the point and the purpose of that. And like you've just said, it is about making a difference to the residents who live in your care homes on a day-to-day basis. And I think some things sometimes are overcomplicated and lost then in translation, and then can only be ever used for research purposes. But to actually have a tool that your care staff can feel empowered with as well. And also, you know, when you share things like that with people, you're sharing the standards, so they know all of the time what the expectation is of the way that they support people and deliver the care. So fantastic.
Well, thank you for that. Thank you. And I think it fits well because we work with these 7 domains of well-being that were adapted and expanded on by Dr. Alan Power. He's written a couple of books, and he's just so easy to read and easy to listen to. He's a geriatrician himself, has worked with people with dementia for a long time. But these 7 domains fit very nicely with our new tools, so we wanted to focus on those. I still absolutely adore all of Kitwood's work, but it complements Kitwood's work, really. So, yeah.
So, do you think that we are where we need to be relevant to dementia care?
No.
I think we're getting there.
Yeah.
I think we're seeing changes now. So, as an example, you know, different models of care are coming out, which are influencing how care homes are designed and how they're built. And we're seeing a lot more providers, Barchester being one, who environment is so important. And I'm not just talking about the enabling environment. I'm talking about the nice looking environment, the place we'd all want to spend time, the clean environment. And it speaks so much about how we're starting to really take dementia care seriously and also value the people who live in those homes. Because years back, keeping harping back to this 30 years ago, but it was very much, you know, you went, there was a smell, wasn't there? And there was always the smell. You could go into any care home and the smell was always the same. I won't describe it, but it was there. The carpets were threadbare, the places were dark. It was a miserable, depressing place.
It was always the poorer part of the home, wasn't it?
It was the poor relation, wasn't it, in a care home. And that spoke volumes about how we valued people who were living with dementia. So you can see the shifts and the changes, but it's not enough. It's just not enough. I think that again comes from, you know, us as a society. We say so much where we put our money where our mouth is, don't we? And I know I won't start banging on about funding, but when you see what funding is made available for our older generation, it's again speaks volumes about how much we value them.
Yeah, and I think that's why I said no immediately, but thinking about people who've just been diagnosed, because even now you're still hearing of people that are having really terrible experiences. They're sort of given a diagnosis and then just left.
Yeah, get on with it. And that's the most... You've been given life-changing news.
Yeah.
And there are no resources available to support you. There's no one there to signpost. There's no one there to answer all of those questions that are so important because they're about your future. And it's...
But if you were given a diagnosis of cancer as an example, you would be then fast-tracked to go and have your consultant's appointment, you know, your radiotherapy be booked, your chemotherapy, whatever it is that you need. And still now we read about so many people that are just left with that. It must be a devastating diagnosis for most people. But then what, like I say, what do they do with that? And I know there was a drive, was it 2 or 3 years ago now, perhaps even a bit longer, to diagnose more people. And I must admit I was a bit militant like you at that point. I'm not saying you're always militant. You said that yourself.
Always militant. I think they're.
But should we, if we're just going to leave people with that, sat with that, ruminating about that, and not having anybody to talk to? And a lot of people have been told, well, come to us when there's issues, when you've symptoms are and needing our expert help. At the very least, people should have access to counselling about their diagnosis if that's what they want to, or to some sort of, you know. I mean, it may be different now, but not from what I've read recently.
Not from my experience, and I think we all know people, you know, with family and friends who are living with dementia, and it's just not there. It's not there until there's a problem, and that's reactive.
But then it becomes a crisis admission.
It does. It's a crisis, and then people are left with limited choices. Then, and you know, I think the introduction of the Mental Capacity Act has been helpful in changing people's way of thinking and understanding that people with dementia, you know, have human rights. God forbid, you know, that's quite a novel way of thinking. Not so that's helped, but then it hasn't. It's all right saying you're entitled to choices, but if the choices aren't there and you're forced into a certain path, then, you know, I think it's like Caroline said before, that's worse in a sense than not being given that choice in the first instance. So I think we've got a way to go, but I think people are demanding more. They're you know, the real experts in all of this are the people who are living with dementia. And more people are speaking out, aren't they? Yeah. And talking about their experiences and trying to shape the services in their own communities and at national level. Yeah.
Which is great.
It's fantastic. And we should all be sitting down, peeling our ears back and listening to what these people have got to say.
And I've probably learned more in the last 5 or 6 years since people living with dementia have been attending the conferences and writing the blogs and writing the books. The very first book I read by a person living with dementia was Christine Bryden. Isn't that awful? It's just Escape Dancing with Dementia. I couldn't remember the title then.
She's written a few, hasn't she?
She has. But it was eye-opening. Yeah. Because most of the people latterly, certainly the last 15 years that I'd worked with, have been people with more advancing dementia. And to hear her thoughts, some of it was validating, great, we're doing the right thing and we're going the right way. And some of it was like, wow, I hadn't actually thought of that.
Oh, okay.
So that sort of affected and influenced our training. I remember writing to her, that's when we were working together, and saying, you know, I've got that many tabs in your book of quotes and stuff that I want to use. Do you mind if I use... It's going to be extensive, but I'll run the PowerPoint past you. And she was great, wasn't she? But each person living with dementia brings us different things. But the thing for me that comes out the most strongly is that need and want to remain independent for as long as possible, to have choice, and absolutely, but to be free from anxiety, the need to feel safe and to be told that they're safe when they're feeling frightened as well. But yeah, each time I listen to somebody or read a blog, you're still looking at it with fresh eyes, aren't you?
Always.
Yeah.
Always. And like you say, you know, every single person brings something new.
Well, yeah,
to
even in our care homes, sorry. I should have.
To
Yeah.
our,
Yeah.
you know, to our knowledge, and
Yeah.
everybody wants something slightly different.
Yeah.
And
Yeah. Which is how it should be.
exactly.
Because we all
Why
want
shouldn't
something.
Why shouldn't we get something
Yeah.
slightly different?
Yeah.
So how do you envisage the future of dementia care? Obviously, we've got a long way to go, but what can you see in your mind's eye around maybe what you'd like to see, or maybe what you think might happen? Obviously, there's probably a gap in between what ideally would happen, etc. But yeah, when you think about what might happen in the future, what does that look like for you?
Do you want me to go first?
You go first.
Well, obviously, I work for an amazing care home company, but I think, in all honesty, people would prefer to stay at home if they could. And I think the future will be about future-proofing homes so that people are able to live more safely at home if they've got a cognitive impairment or any form of disability. I think going forward, you know, builders should think about, you know, everybody's going to become older at some point and or may have something, so we can retrospectively fit stuff or but having that resource behind so that people can stay at home, because ultimately it's the person that's caring for them that probably becomes more stressed and more ill than the person living with dementia themselves.
And that's where the crisis often comes, isn't it?
Yeah, because they don't know where to turn. It seems to be a battle to be able to get anything. Yeah, that's over to you.
Yeah, I kind of think that I'd like to say that there was going to be a cure.
Well, yeah.
But you know, I don't think I'll see that in my
No.
lifetime at all. I remember going to a conference about 4 or 5 years ago, and it was a conference that was attended by professionals but also by residents and their relatives as well. And there was this speaker from some research house, and they were going on about all of the kind of research they were doing into finding this cure, and it was really positive stuff. And after this person had finished, the relative piped up out of the audience. She says, "But what about people who are living with dementia now? What is going on for them?" And there just wasn't an answer. And I think it's like Caroline says, yes, it's, you know, we have to look to the future. We want that cure, but it's about the here and now, isn't it? And it's about making it better in the way that people want it to be made better. And if that means that we stay at home and we stay at home for longer, then we have to make sure that the like say houses are future proofed, but also that the support systems are there, so that it's not just about, you know, if your family are available or willing to care for you, you get care. There has to be something in the support system that allows that to be a reality.
I mean, great that we're getting dementia-friendly societies now, and
fantastic. And you see
some
lots
of the
of positive
supermarkets
stuff.
are, you know, dedicating an aisle that you know can be a bit slower for people if they need to take a bit more time. So there's some great stuff like that that makes it a bit easier for people in the community. But we need to do lots more, really.
A big part of that, although not the whole picture, of course, but a big part of that's going to be around technology. How do you think that technology is going to impact dementia care? Kind of what's happening now, and then what do you envisage happening in the future?
So I think there's some great bits, but I'm nervous about some bits.
Okay.
So things like Alexa. I mean, some of our homes are using Alexa mainly for the radio stations and things, so they can call up music where people have loved the 60s or whatever, or they've said they like a certain song, they can call it up on Alexa, which is brilliant. Some of the wearables for people living in the community, I think, can be a really good thing, because it enables the person to be independent for longer, because they link back to people's phones and things, don't they?
I think we need to give a little bit of thought to the use of CCTV in care homes, because it's quite a hot topic at the moment. And I'm hearing lots of different views and opinions. There's lots of different views and opinions out there, and I'm not quite sure that I've made my mind up yet. Same with the robots, and I know there's that kind of intention that they don't replace people, but that they carry out the more task-based care delivery. However, I think we've spent many years talking about making every task and every intervention count, and making sure that every opportunity is taken to interact with people. It kind of takes away from that a little bit, so I'm still a little bit out there. I think I'm very certain, though, in my thoughts about things like CCTV not being used as a substitute for robust practice. So as an example of that, I don't think you can use CCTV to replace robust values-based recruitment.
No.
You know, you can't fall into the trap of thinking, well, you've got the CCTV there, so that'll pick up, you know, the not so great care. That's completely reactive, and it just can't happen.
It is, and my huge concern is, if that person had got capacity and they were able to say, would they have agreed to have a camera in their room, particularly when they're receiving personal care? And also, if there is a camera in the room, the staff may behave very differently. They may not say as much as they might have said, just because they're fearful that they'll say the wrong thing.
And we see that, don't we? We see that when we're doing observations in DCM.
Yeah.
We see people almost avoiding those interactions, or saying as little and getting out of the room as quickly as possible. And that has to have a detrimental effect on the person's well-being. So yeah, the kind of jury's out with me still. I'm not convinced. I think trust is such a big thing in any relationship, and the relationship that a resident and their relative has with the care home, it's just such a difficult one, isn't it? It really is.
I mean, as you know, most of the media portrayal generally is quite negative, particularly around care home environments. Only recently on Casualty, you know, it could have been there's never a showcase for a really good care home, and people are left really anxious about moving people in, because that's what they see on popular TV programmes.
And I don't think the media give any thought to that.
No.
I don't think they realise that, because for some people the care home is going to be the only option. You know, they're going to need that level of care that can't be delivered in you know, today's community services or at home, and they have to go. Now, if all they've heard from the media is how badly care is delivered, do they even think, do the media consider the impact that has on the person before they actually move into the care home? It must be horrendous to be so fearful of what your future holds, because all you know is that care homes are poor places to be. I'm working with a client at the moment, and they've got such... The place oozes with kindness and love and care. And they had a gent who moved in for a fortnight while the family went on holiday. And when it was time for him to go home, he cried. Didn't want to leave. And we never hear that. We never hear that in the media. But that's becoming more and more common now. And still we don't hear it. It's such a shame.
It is.
You know, it doesn't have to be portrayed
No.
like that. There's got to be a balance. They've got to have a balanced view. I'm not saying for one moment that there isn't poor care out there, but there's also excellent care. And the media have a duty to the general public to put a balanced view out there.
It's not just that. I'm very much of the opinion, as well as being balanced in their approach, also that they've got a certain amount of duty around actually helping to inform and to educate the kind of the populace around the kind of the what's what of all sorts of different subjects. And I think if they don't do that and they have an imbalanced view, then it's going to create whether it be positive or negative, whatever the subject matter is, it's going to create an imbalanced view. And if you're, it's almost, I don't think that it's ignorance. It feels like it is almost intentional, because it sells drama, sells sells papers, or increased attention within a TV program or any of those things. So I think the intention is very much focused on the win for that particular production, whatever it might be, and it's not looking at the bigger picture. And that is, to your point, Sue, that then has a massively negative impact on the public perception of care, because they just think, oh well, I've seen Casualty, and I've read a couple of episodes of the Daily Mail, and I can remember the panorama thing with the Winterbourne view and all of that type of stuff, and that's just what a care home's like. And yes, unfortunately, there are instances where a care home is a terrible place, and we're all very, very conscious of that. And there's nobody of any kind of right mind that thinks that A, acceptable, or B, that shouldn't be used as an incredibly valuable learning lesson, not disregarding the impact on the residents and the families at the time. But as you say, that there's no media channel at the moment that's just purely sharing all that positive content.
To people wanting to do positive productions, we've got the whole issue, rightly, of people's capacity to consent. So it's not, in some respects, it's easier to do the expose stuff, because but even that shouldn't be allowed, because, you know, would that person have wanted that? If they'd have asked that person, would they have wanted that to have been shown on television? Because you've seen close-ups of personal care as well, etc., etc. So even to do a positive promotion, it would still be really difficult, because how do we know that that person really, really wants to take part? However, they could still interview the staff, they could speak to relatives about their experiences of care, you know, if they've got full capacity to say, and to share those good stories, because currently it's just by word of mouth, isn't it? And obviously the publications that we do as nurses, we'll write about stuff and get it published, but often that doesn't change the public perception, because generally it's seen by other professionals. So professionals amongst each other know that 99.9% of the time the care is fantastic, but there are some unfortunately bad people out there, but generally the minute we would find out about something like that, it would be dealt with. But you can't always tell from interview that somebody's going to be a bad person.
One of the good examples recently was the restaurant that makes mistakes. I know there were a couple of let's say mixed views on that, but I watched that, and that really I found that really quite heartening, because it was it seemed like a very kind of honest and authentic set of circumstances where the public had an opportunity to be able to see people living with dementia and what that actually meant for them. And then some people said, we had a discussion, didn't we, around somebody that who'd kind of lambasted the show because they felt that they were kind of almost making a mockery of the people living with dementia. And I think that was a very negative view to have.
She was actually a leader in healthcare in university, and she felt that the praise that they were given was quite patronising, and I was quite shocked actually by her write-up of it, because I didn't see that. I saw that people wanted to take part. They asked them for their consent every day. They got real value out of it, didn't they? My only part was what was going to happen afterwards. But people have started national campaigns. I think TGI Fridays has started to create some spaces for people
And I think it goes back to what we were saying earlier about listening to the experts, and the experts are the people who are actually living with dementia. And just as you've said, what did they gain from it? Forget every other specialist and person with an opinion and a pair of eyes in their head. Does it really matter to the people who had that experience and enjoyed that sense of purpose and felt like they were contributing? Because we all need to feel as if we're contributing something. Does it really matter what other people think? And I think we seriously need to open our ears and start listening better. Unfortunately, I think, and you know, I know Caroline and I have discussed it in the past, sometimes the field of dementia is exploited. So Caroline can sell a jigsaw for £5. I can call mine a dementia jigsaw and sell it for 50. And it's like, how much are people actually in it to genuinely serve and develop services for people living with dementia, and how many people are in it to make a name for themselves? And I think we've seen lots of people over the years.
I remember again, I think we were together at that care show when somebody was advertising the dementia plates. And me actually questioning them and challenging them as to why it was a dementia plate. I said, has it got dementia?
It was because it was £30 more
Yeah, it's
expensive than the plate next door.
Yeah.
And you know, that's the kind of thing that I know causes me a lot of frustration. Really, it's never about the one person. It's about the collective strength, isn't it? And if we're all singing from the same hymn sheet and we all want to make things better, then that's far more useful for the person living with dementia than it is some woman spouting about her views on whether it was patronising or whatever.
You seem to be touching upon there around culture. What's your opinion on how impactful culture can be on the provision of dementia care?
I'd say hugely.
Massively.
I think just the very fact that we've started to change the language around dementia over the last, particularly 15 to 20 years, as we've both said at the start of our careers, people were very much labelled with their dementia as well, weren't they? And everything that sort of came with it, and they didn't really see the person behind it. And people were always violent and aggressive and
wandering.
Wandering, and or doubles.
Singles.
God, yeah, it was just awful.
Leaders.
But that just helps to create that task focus. We don't see the person, we see the dementia. And I think some of that is around the medical model as well, where we think too much about what happens in the brain rather than actually the symptoms of whatever that person's experiencing. And I think since we've tried to soften the language, people have, and it's not just about softening the language, it's about getting people to think about why is that person distressed. So before, if we said they were violent because they had dementia. Whereas now we're trying to say they seem to be distressed. Why do you think they might be distressed? Is that because we've approached too quickly? Have we given time for the person to hear what we're saying, for them to make that choice back to us? Is it that, you know, we've gone and swished somebody's curtains open and they just actually weren't ready to wake up? And just getting people to stand back and think about, actually, if that was me, how might I respond in that situation, even, you know, if I haven't got dementia? But then if I was confused and disorientated, possibly anxious, how might that be exacerbated? And often if you relate things back to everyday life, and Christine Bryden really started it off with talking about adaptive behaviour, that she's adapted to her environment. She says quite strongly, you know, I haven't got challenging behaviour, I might have adaptive behaviour because of things that are happening to me or at me. Kate Swaffer has really talked about, you know, we need to eradicate BPSD and challenging behaviour. And I'm really glad that, you know, everybody's starting to think about it. Sometimes we struggle when external assessors come in, because if they don't see those terms, they assume that the person's okay. And I was actually had to have a chat to one of our relatives who said, because your terms are so fluffy, my wife can't get continuing healthcare funding because they're looking for those
keywords, aren't they?
Yeah.
Right, got you.
That indicate
Yeah.
that there are complex
Yeah.
needs. And I mean, it's a really, really difficult one,
It
isn't
is.
it? And it's about how do we... It's getting there.
Yeah.
You know, even 10 years ago, people hadn't considered, apart from Caroline and her team, really, alternatives to that challenging behaviour. And now you're hearing more of people referring to distress, but it needs to be collectively accepted in order that people aren't then penalised and have the funding that they need to receive
But generally,
the
I
right care.
think it is.
Yeah.
So I've just written an article actually about distress and saying that it was 10 years ago when I wrote that first
Yeah.
article, Throw the Gauntlet Down. I think universities adopt the term. Certainly most of the healthcare independent sector will adopt the term.
Yeah.
But the NHS are still
We're still not
quite
there, are we?
stuck.
Yeah.
And I'm not sure what that's about. But for me, it stops the staff blaming people
Yeah.
with dementia. I think,
And it also allows the team to understand what a massive impact they have
Yeah.
on how somebody feels and actually then how somebody reacts.
yeah,
And you know, it's quite an eye opener when that penny drops and
Yeah.
you realise that that person might just have done that because of something that you did.
and that I think for us became very apparent when
Yeah.
we were using DCM to a great extent. And as an example, you'd see that a person would be sat in their chair, just happily watching what was going on around them, and one carer would come up to the person and say, "Sue, would you like to come and join the domino session that we're having?" Sue would say, "No." Carer number 2 would come along. "Come and have a go at the domino session, Sue. We're all there over the table, so all good intentions." No. Third person would come along. "Oh, come on, Sue. Come and have a..." And actually take Sue. And then Sue would become quite distressed and push all the dominoes off the table. And that member of staff would be quite shocked and thinking, what on earth? Not realising that another 2 members of staff had already asked Sue if she wanted to go to the domino session.
And
she
she's
said
perfectly
no.
comfortable and happy
Yeah.
and doing what she's
Yeah.
doing. Yeah.
Being nosy, usually.
And being assertive is a good sign
Yeah.
of well-being. But people, because they think, oh, well, she's got dementia, she doesn't know what she's saying. So she's not just saying, she's just saying no. She probably wants to be there. So it's talking all through that detail with staff about,
Yeah.
and that's where the observational stuff can be really critical to help staff to understand why people might become distressed. And
That works really, really well in a culture that is about learning lessons
Yeah.
and making improvements and not blame. And I think people are getting better, aren't they, at setting out their vision and their values, and you know, saying this is what we stand for in this home. But I've known lots and lots of people that don't quite then carry it through. They don't look at translating that then into practice. So what does caring look like? You know, because it looks different to everybody. You know, 30
Yeah.
years ago we thought we were caring, and actually we were anything but, really. So having that solid behaviour framework that sits within your culture piece is absolutely integral. You know, it's vital that is there, and that you follow it through as managers and as leaders, and that everybody understands what the expected behaviours are. If you don't have that culture, we're never going to be able to build on these fantastic initiatives and this person-centred and valuing staff kind of approach.
And sorry.
No. What are you gonna say?
Often inspectors will ask us to provide restraint training. across the board for a given home. So, unfortunately, occasionally you do get a resident that's lashing out at a member of staff. But when you unpick that often, that's the training that we need to do. We phone the homes and say, you know, when we've got an alert through. But my worry is the Winterbourne thing. That once somebody's trained in restraint, it becomes the first line response.
Treating the symptom, not the cause.
Yeah.
So it's dealing with once the negative feeling has been manifested in the resident, and their behaviour has changed in accordance with the way that they're feeling. It's then dealing with the kind of the outcome of that, and it should have been a case of okay. So let's make sure that the resident's feeling good about the rod. Exactly, and comfortable and not anxious and. In a good environment where they don't feel stressed.
I still think the restraint training is a part of that old culture. We have restraint training, you know, and we had restraint training because we didn't have this knowledge. We hadn't, as a generation, I think, we hadn't sat down and thought about the things that we think about now. And I think it's dangerous to start a blanket across the board saying you need restraint training, because like you say, it becomes a first resort. That's what we use, and we stop doing all that thinking that you and I have spent years and years and years encouraging people to do. It's a backward step.
But also, if you're not using it very often, are you going to deliver it in the right way? So you might be trained, but then actually you don't use it for 2 months. But then am I actually going to cause more harm because I'm not using it regularly? So I agree it should be delivered in acute psychiatry, because obviously you get people with quite acute psychosis. But in dementia care, when people are 80 odd,
come on,
well, they're not all 80 odd, obviously, but do you know what I mean? When people are potentially frail and, well, anyway, as you were rightly saying, Simon, and you know, you don't work in dementia care as such, but it's more a case of us looking at a person and thinking, they look a bit worried or anxious or lost, and getting over there before that's escalated and the person's become distressed, and us communicating, making sure people have had time to respond or think about what you've said. So it is almost about getting the staff to not blame themselves, but reflect on.
Got to ask themselves the question why before they start acting upon whatever set of circumstances.
I mean, for a very small number of people, then it may be that they're having a very active or vivid hallucination and are scared by that hallucination and are responding to that and perhaps hitting out at whatever the person's seeing or hearing. But yeah, for the most part, I think, we've reduced the incidence within our company by over a third within a year of rolling out stress reaction training.
That's massive.
It's massive.
It's huge.
Yeah. I haven't analysed the figures lately, but it is all that, and sort of we have this clinical governance system that sort of alerts me if there has been one, and immediately I'll forward it to the specialist and say, can you just give them a ring, talk it through, see why this happens, so people are starting to become more analytical as well. But yeah, it's sort of moving away from the ABC charts. So we've developed our own form called the Decide, which gets people to reflect, think about, what's happened, look at the pain, measure the pain, were they in pain, look at the Cornell scale, look at the wellbeing scale, what was happening at the time, how might we do it differently if we went and did it again. So yeah, it's I think we're getting there, aren't we?
I think so. We're certainly in a better place now than we were 30 years ago, aren't we?
Hopefully, yeah.
That is good.
Yeah.
How important do you think effective leadership is relevant to dementia care provision?
Sorry.
How important do you think effective leadership is for dementia care provision?
Extremely important when we think back to how we were led. That actually, for the most part, it was the wrong way. Don't get me wrong, there were some great sisters and charge nurses, but nobody listened to when we wanted to make changes or try and question what was happening. And I think to be a good leader in dementia care, you've got to be a good role model primarily. That you're facilitating what should be happening. What do you think, Sue?
Yeah, and I think you've got to be very, very open-minded, and empower people to try new things, and to almost have this really fresh attitude of anything's possible.
Yeah.
I think you've also got to recognise that your people are your biggest asset.
Yeah.
Your team is your biggest asset, and therefore should be treated as such. And nurtured and developed and cared for, because without that, if people don't feel valued or even valuable, they won't give their best, will they?
No.
So I think leadership is, like Caroline says, a lot about role modelling, but also nurturing the best out of your team.
And supporting the team when things haven't gone quite right.
Yeah.
Because sometimes it can be disheartening, I suppose, in dementia care. Not disheartening, that's not the right word. Emotional. And sometimes you come away, if you haven't been able to find an answer, something particularly for a person that is quite distressed, and you haven't got to the bottom of it for them, that can be quite it's like a load that you feel that you're still carrying because you haven't got to the bottom of it. So it's all about providing coaching and support for the team and supervision for those circumstances, and perhaps when they've worked with staff that don't or aren't ready to move, should I say, rather than don't want to move. But I suppose I did a great leadership course which was about days and management, which was just fantastic, with a guy called Sid Johnson, who was on the BBC, and it's just a simple concept about, well, he wouldn't thank me for saying that, would he? Because he became a coach in this. No. But the primary concept of it was turning that pyramid around, and like you say, listening to your people on the ground that are saying this doesn't work for whatever reason, and even if it's been tried and tested before, let them try it again, because time's moved on, it's different people, well, let's try it again, let's test it again, rather than we've been there,
we've done that, it didn't work.
Baby out of the bathwater type thing.
Yeah. So, like you said, just being open to ideas and,
So, Caroline, question for you. So, if you were to give somebody looking to make a positive impact in the care sector one piece of advice, what would that piece of advice be?
Always maintain a positive outlook that everything's possible. If you want to do something, start small, probably. Demonstrate how and why it'll work. And just keep pushing for funding for it if you believe it's going to make a real difference, I suppose, yeah. Tenacious. Be tenacious.
Tenacious.
Yeah, but for the main part, just always try and keep a positive outlook that anything's possible.
I like that. Yeah. It's a nice piece of advice. How about you, Sue? What would be, if you were going to give somebody looking to make a positive impact on the sector, what advice would you give?
I think my advice would be about keeping a very, very open mind, accepting that absolutely every single day is a school day, and we are always learning. And to learn from everything and everyone around you, because I think the minute you think you know everything, and the minute you close your mind to new ideas, you're limiting then the improvements that can be made in the sector. So open-minded, keep learning.
Another great piece of advice. And Caroline, what's the best piece of advice that you've ever received?
Well, that's
personally?
why I was tittering as you said that, because the best piece of advice I had and it was of my father, was that you never stop learning. And I didn't really understand it when I was still at school, but particularly in dementia care, it's become so apparent that even when we think we've got something cracked, actually there's still so much more to look into and to explore and to try and improve. And so yeah, sorry, that's why I was amused when you were saying your bit. I thought, gosh, you were in my head, my dad's head.
How about you, Sue? What's
Actually,
your best
that's
piece of
a
advice?
bit spooky, because I think most remembered and the advice that I've lived by was also from my dad, who said never regret anything. You know, you make choices and they're the right decisions to make at that time. And if they don't pan out, if they don't work out, then don't dwell on them, but learn from them. So I don't have any regrets. I have made lots of mistakes, but I learn from them. And he also said, be kind. And, you know, that every day, you know, kindness costs nothing. And if we can't be anything else, we can be kind, can't we?
I think there's a huge amount that people are going to get from this episode. Thank you both so much for joining me. I hope we can do another episode again in the future. So, Caroline, it's been an absolute pleasure.
Thank you for asking me along, Simon.
Wonderful. Thank you
Thank
very
you
much.
for having
Nice to
us.
chat to you, Sue.
Yeah, lovely.
That was a lot of fun. Thanks, guys.
Thank you.
Thank you.